Hi everyone, Happy New Year. I'm Dr. Catherine Palmarola from IVFMD Miami, and welcome to our January first week on fertility discussion. So tonight we'll be discussing amenorrhea. So first, what is amenorrhea? Amenorrhea is when there is no menstruation, absence of a period. We classify amenorrhea into two different categories. Primary amenorrhea, if the patient or the woman has never before had a period ever in their life, that would be considered primary amenorrhea. Secondary amenorrhea is the absence of a period after previously having periods. So how do we diagnose amenorrhea? Primary amenorrhea, if you've never had a period, we recommend evaluation and workup. If you are 14 years old and you have no secondary sex characteristics, meaning no breast development, no pubic hair development, so absence of period by age 14 would be considered primary amenorrhea without showing signs of breast or pubic hair development. Secondary amenorrhea, going back to primary amenorrhea, if there is breast or pubic hair development, primary amenorrhea is considered if there's no period within 5 years of the start of breast development, or typically by age 16. So secondary amenorrhea for women who have had previous periods, we consider workup if there has been 3 menstrual cycles or at least 6 months with no menstruation. That would be an indication for workup. So what are the different causes of amenorrhea? Certainly the most common causes vary whether you have primary versus secondary amenorrhea. So primary amenorrhea, the most common cause, almost 45% of patients with primary amenorrhea have gonadal failure, meaning failure of the ovaries. The next most common at about 15% is congenital anomalies of the reproductive tract, so absence of the uterus, absence of the cervix, absence of the vagina, or various other structural changes that may prevent the outflow of blood. About 15% of cases of primary amenorrhea are caused by that. Finally, at around 10%, there's a constitutional delay accounting for the primary amenorrhea. In terms of secondary amenorrhea, these are women who've previously had periods but now have gone 3 cycles or 6 months without a period. The most common causes at around 40% are chronic anovulation. This would be things like PCOS or polycystic ovary syndrome. The next most common are disruptions in endocrine factors like thyroid or prolactin. Changes in these hormones can result in changes in your period. And then about 16%, or the next highest cause of secondary amenorrhea, will be weight loss, anorexia, or overexercising. So in terms of workup, there's a couple of reasons that are normal to not have periods, the most common of which is pregnancy. So certainly if you are pregnant or recently delivered and are still breastfeeding, this would be considered a physiologic cause of amenorrhea and a reason not to be getting the periods. Certainly before puberty onset, it is normal to not have periods. So onset of puberty on average is between 9 and 15 years old, but certainly based on family circumstances, family history, there may be a later onset of periods. So this would be considered another physiologic cause of amenorrhea. And then finally, women who've entered menopause, the average age of which is 51, it is normal to not have your period. So those are normal circumstances to not be getting your period or to be amenorrheic. But outside of those instances, a workup and testing is indicated. And this is why many gynecologists consider the menstrual period to be an extra vital sign and an indication of your health. So what is the testing that we do for patients with amenorrhea? Like all medical conditions, we begin with a very thorough history and physical. In terms of the history, especially for young girls with primary amenorrhea, we want to know about their onset of breast development, if any, onset of pubic hair development, if any. Especially, it's important if they've previously menstruated. Are we in a scenario of secondary amenorrhea? The frequency of those periods, Have you had any prior uterine surgery for removal of fibroids or polyps or any other indication to do surgery on the uterus? This can cause scar tissue, and depending on the location of scar tissue, this may drastically reduce the amount of blood loss or sometimes even cause you to miss periods completely because of the amount of scar tissue inside the uterus. It's important to know if there have been prior pregnancies, and if there were prior pregnancies, were there any complications around the time of delivery? Anything like an infection or difficulty delivering the placenta can result in scar tissue formation after that pregnancy. Early deliveries, preterm deliveries, especially deliveries that are prior to viability, before 24 weeks, these types of pregnancies are especially prone to infections following delivery, difficulty delivering the placenta, and formation of scar tissue. So your fertility provider will ask you many questions about prior pregnancies to gauge risks of formation of scar tissue following those deliveries. Have you had many miscarriages, and as a result, many procedures on the uterus? Again, these can cause scar tissue not only within the uterus, but sometimes also within the cervix, even to such an extent that the cervix becomes closed, or something we call cervical stenosis, and will prevent the outflow of blood, resulting in no periods. It's also important to know family history. Did the women in the family go through, have their first periods very late in life? This may indicate a constitutional delay. Or similarly, have women in your family had premature menopause, and as such, you might be at risk of early menopause or gonadal failure. Also, any history of abnormal puberty or abnormal hormone regulation in the family may indicate a genetic reason for abnormal periods or absence of periods. In terms of the physical exam, the provider will be looking for evidence of secondary sex characteristics, so breast development, especially for girls with primary amenorrhea, the extent of their breast development or pubic hair development, both axillary and genital pubic hair. Evidence of excess hair growth, so hair on the chin, neck, face, chest, lower abdomen, back. This may indicate other causes of amenorrhea, especially in secondary amenorrhea like PCOS, polycystic ovary syndrome, congenital adrenal hyperplasia, or other androgen secreting tumors or abnormalities that can influence the menstrual cycle. In addition, your provider will be evaluating the breast for any evidence of nipple discharge, evidence of high prolactin levels. This is again the hormone that results in breast milk production. It's normal to be high in lactating women, and this will be part of the reason why women do not menstruate with their breastfeeding. But outside of breastfeeding, the production of breast milk or nipple discharge is not considered to be normal, so a reason to be worked up. They'll be doing a thorough exam of the genitalia, looking at the vagina for evidence of estrogen production. Is there nice pink, moist vaginal mucosa indicating presence of estrogen? Or is it a hypogonadal state, pale vaginal mucosa, absence of nice vaginal mucus, which would indicate low estrogen levels in a hypogonadal state? This can be seen both before the onset of puberty as well as in the menopausal state. They'll be evaluating the vagina to make sure it's a normal length and make sure there's a presence of a cervix at the end of the vagina. A very shortened vagina and absence of the cervix may indicate certain Mullerian anomalies or abnormalities of the reproductive tract, failure of the uterus to develop, or absence of the cervix. These are all possible if we see evidence of abnormal size and shape of the vagina. Sometimes there can also be a septum, which is a excess tissue that may be occluding or blocking the outflow of periods, or even an imperforate hymen. Hymen is the very thin tissue at the very exit of the introitus, the very exit of the vagina. Often, if a young girl has an imperforate hymen or a transverse septum, these are often things that are picked up very early in the girl's menstrual history, because every time a period occurs and the blood is blocked from coming out, it can be very, very painful, often resulting in emergency room visits. So luckily, or hopefully, these types of diagnoses for primary infertility or primary amenorrhea are diagnosed very early in the case. In addition to a thorough physical exam, often an ultrasound will be performed. And on ultrasound, it's important to identify the uterus, make sure that there is a uterus. There are causes of congenital absence of the uterus. Also evaluating the size of the uterus. Before puberty, the uterus is very small, hypoestrogenic. So we would be measuring the size of the uterus and looking at the lining of the uterus, the endometrium, to make sure it's a normal estrogenized or progesteronized lining of the uterus, depending on the time of the month. Also evaluating for the presence of ovaries. Certainly, if a patient is born without ovaries, that will definitely prevent periods from occurring. We'll also evaluate for the presence of cysts or abnormal tumors that might be producing hormones and preventing normal, regular periods from occurring. In addition to thorough physical exam, we also perform many blood tests, the first of which is often a pregnancy hormone test for whether it's primary or secondary amenorrhea. It's very important to make sure that pregnancy is not the cause of missed periods. Additionally, we check hormone levels related to the ovaries, the gonadotropins, FSH and LH, as well as estrogen. FSH and LH are two hormones that are produced by the brain, specifically the pituitary, in response to signals from other parts of the brain. And these two hormones, FSH and LH, communicate with the ovary in order to grow follicles each month, release eggs, which in turn produce additional hormones to cause menstruation or help to support pregnancy. So the FSH and LH are critical to see if we have a normal hormonal state, if the hormones are very, very elevated, which can indicate gonadal failure, either a menopausal state. There are various reasons for very high gonadotropins and gonadal failure. This may be a chromosome problem, meaning Turner syndrome, where a woman is missing one of her X chromosomes. These patients often go into gonadal failure, sometimes even before puberty, before the first menstruation. Gonadal failure may be a result of prior chemotherapy or radiation or other medications that impact the ovaries, or there may be an autoimmune condition, antibodies that have attacked the ovary that result in gonadal failure. If the FSH and LH, if these gonadotropins are very low, this indicates a hypogonadal state or low hormone state. This can sometimes be due to chronic diseases. The body is actually very smart, not surprisingly, but if there are chronic illnesses, chronic kidney disease, hospitalization for shock or long-term medical conditions, very serious medical conditions, often the body is smart. It recognizes that it doesn't have the resources to support a pregnancy at this time, and it, in a way, shuts down the system. So the brain stops sending signals to the ovaries to grow eggs so that pregnancy is not possible, because the body needs to conserve energy, conserve resources to treat the other medical conditions that are occurring. So chronic diseases may result in a hypogonadal state or low hormone state. There may be brain tumors, either both benign or cancerous, that can result in changes in the release of hormones. This would be evaluated with an MRI or a CT scan of the head. Even very small benign tumors within the specific area where these hormones are produced can influence the release of these gonadotropins and prevent normal periods from occurring. So even very small tumors, less than a centimeter, can have these changes. A patient may never have any symptoms, but this is why often in the workup of amenorrhea, sometimes a scan of the head with an MRI or CT is often recommended. This may also be the case in patients who are suffering from eating disorders, especially anorexia, where the body weight is significantly below normal, or in cases of extreme athletes or over-exercisers. This can similarly result in low hormones or a hypogonadal state and prevent periods from occurring. Most common in sports where weight is critical, so gymnastics or crew, running, these are all higher, ice skating, these are all higher risk sports to have hypogonadal state. Sometimes these hormone levels can be normal, but still result in abnormal periods. So a very rare syndrome called Kallman's syndrome, this is where the parts of the brain that signal to the pituitary to release the FSH and LH gonadotropins fails to develop early in life, early in embryonic development. Certainly, it's the hypothalamus that is talking to the pituitary. If this connection does not develop, then there's a break in the telephone system, and the signal is never developed to talk to the ovaries to develop the follicle, to ovulate, and result in menstruation. So this is a very specific rare disorder called Kallman's syndrome, but may result in normal FSH and LH levels. There may be a physiologic delay. Maybe in your family, women tend to have later periods. So this would certainly be a cause of normal hormone levels and absence of period. Patients with chronic anovulation due to conditions like PCOS or congenital adrenal hyperplasia, or women with obesity, Cushing's syndrome, these may all result in normal gonadotropins, but still absence of period. In certain conditions, we do recommend checking a karyotype, which checks the number of chromosomes, and specifically identifies patients who appear externally as physiologic females, but actually by chromosomes contain the Y chromosome, which is the male chromosome. The most common condition of which is called androgen insensitivity syndrome. So while the patient has a Y chromosome and testosterone is being produced, it's the receptors to those testosterones that malfunctioned and are unable to result in the male secondary sex characteristics. So during embryonic development, in the absence of normal testosterone signaling, the female system develops and the patient appears as a female. A similar condition or a related condition is another very rare enzyme deficiency called 5-alpha reductase, which is also important for testosterone action. If this is absent or malfunctioning, again, during early embryonic development, when signaling of testosterone is critical to the development of a normal male system, if this enzyme is absent, the female system will result. The patient appears externally as a female, though the chromosomes indicate that it is male. Additionally, a karyotype or chromosome testing will indicate whether the patient is suffering from Turner syndrome. Turner syndrome, normal females contain 2 X chromosomes. In Turner syndrome, there is a complete absence of one of those X chromosomes. There's also cases of mosaicism where some of the cells contain 2 chromosomes, but others contain 0, or just 1 X chromosome. So Turner syndrome, they are at risk of early gonadal failure, often before the onset of ever having a period. In the case of mosaicism, sometimes patients do have periods and then go through early gonadal failure. In the setting of, if we're concerned about gonadal failure, another test that is commonly done is the FMR, or Fragile X syndrome testing. This is a genetic defect causing often mental retardation in males, but in females, there is a high risk of early gonadal failure. Additionally, in the setting of a gonadal failure, we'll do several immune testing. Autoimmune conditions or antibodies against the ovaries may result in gonadal failure or absence of menses. So women who have one autoimmune condition are definitely at higher risk of having additional autoimmune conditions. So we would test for antibodies against the adrenal gland, against the thyroid gland. They are at higher risk of diabetes and other autoimmune conditions, which we would test for as well. Very, very specific enzyme defects, like I mentioned before, 5-alpha reductase. There's a couple of other enzyme deficiencies that may result in gonadal failure or absence of menses. Based on the prior history, physical, and workup, these very specific enzyme deficiencies could be tested for as well, making sure you're working with the right laboratory that can identify these accurately. If we're concerned about intrauterine adhesions in the setting of secondary amenorrhea, prior pregnancies, maybe there was difficulty delivering the placenta, maybe there were infections after delivery, something called a saline sonohystogram, or a study where we do an ultrasound and instill water inside the uterus, we'll be able to identify any scar tissue within the uterus that is preventing normal menstruation. So how do we, if you're diagnosed with amenorrhea, we've identified a cause, what can we do for treatment, specifically trying to get pregnant? So this clearly varies significantly based on the specific cause of amenorrhea. So just broadly discussing some of the more common reasons. If you are in a hypothalamic or hypogonadal state, again, this may be due to chronic medical conditions. First goal is to address those chronic medical conditions, and often with improved health, the menses will return. Again, the body is smart. If there are not sufficient resources or energy stores, it will shut down the system that promotes pregnancy because it needs to conserve resources. But once those conditions are treated, cured, or managed sufficiently, often menses will return. If we're in a situation of anorexia or overexercise with sufficient weight gain, often menses can return. Improving exercise, eating habits, reducing exercise, achieving an optimal weight BMI greater than 18.5. This will often result in the resumption of menses, and it's also an indicator that that patient has achieved a more ideal weight. So patients who are in a hypogonadal state, meaning low hormones, they typically do not respond to our classic treatments for infertility like Clomid and Letrozole. These are pills that we take to increase egg numbers. These types of medications rely on a normal gonadal function, normal release of FSH and LH from the pituitary. So in a state of continued hypothalamic status, despite optimization of other medical conditions, optimal weight gain, often these patients will require injection gonadotropins in order to help with follicle growth and ovulation. So an injection gonadotropins, this is where we give medications of LH and LH, FSH and LH, instead of relying on Clomid and Letrozole to increase the natural production of FSH and LH. With the injection gonadotropins, these patients often respond very well. Sometimes it's not a game, but sometimes it can take a while to find the optimal dose to achieve a response, but then the patients do tend to respond very well. If we're in a hyperthalamic state, meaning very high FSH and LH, this unfortunately indicates gonadal failure, meaning complete early entry into menopause, most likely, and failure of the ovaries. Unfortunately, at this time, we don't have adequate treatments for a hyperthalamic state in order to reduce or reverse this process. So patients who are found to be in gonadal failure, options for treatment are usually limited to egg donation. Depending on the specific cause, the patient may be able to carry the pregnancy, but often relies on donor eggs in order to achieve pregnancy. Of course, there's also the option of adoption or foregoing pregnancy. But unfortunately, at this time, we do not have treatments for gonadal failure. There is hope that possibly stem cell therapy, stem cell injections, platelet-rich plasma injections possibly may reduce or reverse some of these effects, but at this time, these are all considered experimental and far from routine use in humans. If there is found to be a structural defect causing the amenorrhea, for example, scar tissue within the uterus, a surgery, hysteroscopic surgery, can be performed to break up that scar tissue and achieve a normal cavity. Sometimes additional hormone support after the surgery is needed to build back that lining of the uterus and result in normal menstruation. But depending on the extent of tissues, often this extent of scar tissue, often this surgery can be very successful. If the patient is found to have a septum, meaning a thick band of tissue within the vagina that's preventing the outflow of period blood, this can be a surgery to remove the septum and result in normal resumption of periods. Similarly, if the patient's found to have an imperforate hymen or the very thin tissue at the base of the vagina, this is a very quick surgery to remove the hymen and result in normal flow. In certain circumstances with like congenital absence of the uterus or something called Meyer-Rokitansky-Kuster-Hauser syndrome, or MRKH, something you may have heard, at this time, we actually do have the option of uterine transplants, either from live donors or cadavers, where women are able to receive the uterus from another person. These, after an extensive transplant surgery and immunotherapy to prevent rejection, as well as additional hormone therapy to support the growth of pregnancy. Pregnancies have been achieved and live births have been, babies have been born from patients with uterine transplants. This is still considered fairly experimental. There are only a few centers in the world that perform this surgery. But if this is your scenario, certainly you can talk to your fertility provider and they will be able to put you in touch with the centers that perform this surgery. Alternatively, patients with absent uterus or absent uterus would require, you would be able to use your eggs, but a gestational carrier to carry the pregnancy as there is no uterus. Very rare is congenital absence of the cervix or congenital absence of the vagina. In this scenario, women have their eggs and their uterus, but they are missing the connection to allow sperm into the uterus and normal ovulation to result in pregnancy. So in these rare scenarios, pregnancy absolutely is still possible through in vitro fertilization and then implantation of the embryo directly into the uterus, often transabdominally, or if a new vagina is created, which is also possible. So depending on the specific structural abnormalities, often a surgery may be possible, or in the situation of MRKH, Meyer-Kuster-Rokitansky-Hauser syndrome, possibly the use of a gestational carrier. If there is an endocrine etiology of the absence of periods, certainly correcting the thyroid level or correcting the prolactin level will result in resumption of normal menstruation and possibility of natural pregnancy without other fertility medications. In cases of chronic anovulation due to polycystic ovary syndrome or congenital adrenal hyperplasia or Cushing's, first addressing the underlying metabolic conditions, optimizing weight, which can often be elevated in these conditions. Once metabolically the patient is stabilized, these patients often respond very well to routine fertility medications like Clomid and Letrozole. Sometimes in very resistant cases of PCOS, we do have to resort to gonadotropins, and in these circumstances, patients often do very, very well. Finally, if there is a physiologic cause of the menopause, either the patient is still prepubertal because there is a very late family history of menstruation, just watching and waiting, and menses will come, but following up routinely with the gynecologist to ensure that there is no other conditions that have developed that may result in absence of periods. Certainly if a woman is lactating or is breastfeeding, sometimes it can take several months after stopping breastfeeding to achieve normal menstruation again. Again, watching and waiting will result often in periods within the next 3 to 6 months. And of course, if pregnancy is diagnosed, that is an obvious cause of abnormal periods, and your provider will monitor you from there. So that brings us to the conclusion of our January first week on fertility. I hope you all learned something educational, helpful for either yourself personally, or often friends or family may be affected by amenorrhea. It was wonderful having you, and I look forward to seeing you next month. All right, have a good night. Take care.